Thank you so much, everybody who might be viewing this webinar. We are just delighted today that Friends for Survival was able to put together a very special, unique kind of webinar, different from what we've done in the past, but it's called Ask the Authors. And we have two authors with us today who have co-authored a book. And we thought that the balance between someone who has actually had a personal family member die by suicide and a professional psychologist would be very helpful. So I'm going to let each of them introduce themselves. They have co-authored a book called Touched by Suicide, Hope and Healing After Loss. And it is a wonderful book. It's been out for quite some time. I can't even think how long, but I'm sure they can tell us because I read it many, many, many years ago. So I've been very grateful to have the opportunity to have met both of them from time to time. And I first met Carla when she called me on the phone when she wrote her first book that she wrote by herself called No Time to Say Goodbye. And I was so impressed because she called to find out if the references that she was going to put in the back of the book were actually available services for families after a suicide death. And I was so impressed that she would make sure that that list was updated and everything. So that was my first experience with Carla on the phone. And I've seen her in workshops after that. So Carla, I'll let you start and your introduction and tell us a little bit more about you and your loss.
Well, thank you, Marilyn, and thank you, Friends for Survival. This is really my honor, our honor, to be able to reach out to all of your listeners and people that really care about this subject, anyone who has been touched by suicide. I'll give you a brief introduction. My name is Carla Fine. I live in New York City, and I lost my husband, Harry Rice, who was a physician here in New York City. He was 43 years old. We had been married for 21 years. He killed himself at the age of 43. I knew nothing about suicide at the time, and my life really changed at that. I was always a writer, and it took me a couple of years to realize that I needed to write a book about what it was like to survive the suicide of someone we love, because I couldn't find anything out there that was so different, because I believe that suicide and death are kind of two different subjects. So I wrote No Time to Say Goodbye, Surviving the Suicide of a Loved One. It came out in 1997. It's still out there. And shortly after, Mike and I connected, and I'll put in a real plug for him. He's a real humanistic psychiatrist, guys, MD, with who really cared about those of us who've lost loved ones to suicide. And we became colleagues, and then we co-authored the book together that you're saying. Since then, we have given lectures and workshops together, dealing with, since Harry was a doctor, Mike specializes in physician suicide as well. So we went to medical meetings as well as survivor meetings. And we also co-host a workshop on writing through healing. We do a thing together where we do writing exercises and we talk about it. So I look forward to all the questions, and thank you again. And I'll throw it over to Mike.
Yeah,
Okay.
welcome, Mike.
Hello, everybody. I feel very welcome, and it's an honor for me to be here to see you again, Marilyn, and to do this with my dear friend Carla and Friends for Survival. Just a brief note about myself. My life was first touched by suicide when I was 19 years old, when I was in medical school. And one of my roommates, there were four of us, died by suicide over the Thanksgiving weekend. I was the last person to see him alive before the Thanksgiving weekend. And I don't think I realized it at the time, really, how much Bill's death would really shape my career. I finished medical school, and I began to notice and just have so many patients come into care in hospitals while I was a student. Then I interned in Los Angeles, and then I did emergency medicine in Detroit, and then I was back in Los Angeles doing internal medicine. And it was at that point, after looking after so many individuals who had made near lethal suicide attempts or died by suicide under my watch in the hospital, that I had this feeling that I wanted to see if there's some way that I might be able to work in a branch of medicine and to perhaps help or intervene at an earlier stage before this. So it was actually suicide that attracted me to psychiatry. And so I was always aware of that I would be looking after suicidal people, and also that I would lose patients to suicide. It's just the way it is. When you work in a branch of medicine where you look after a lot of seriously ill people at times. And then so fast forward then to, doing that for some years. And then, as Carla said, then we met and our collaboration began.
Well, I am thrilled that you met each other and have collaborated on this newer book that was published. What year was that book published?
I think in 2007 or 2000.
7? So it's been about 15 years probably.
Right.
It's a great book, and it's a very interesting format that you have in that book too. So I encourage people to get that book and get some additional information. But today, what we're doing, this program is called Ask the Authors. And so we have had our families from Friends for Survival that are getting services from our organization that have submitted questions ahead of time so we can record them and more efficiently answer questions. And so we have 10 questions that have been submitted, but many more were submitted, but we kind of had to pare it down to at least 10 that they could each answer different. I'm sure sometimes one or the other is going to answer the question. So I will start with question number 1. And the question number 1 is, how has our societal understanding of suicide changed in the past 20 years? Or you can say 30 years even.
So Carla, go ahead.
Not much. And I can say 30 years because Harry died 30 years ago. I think how it's changed for me personally, it's much more in the news. It used to be much more hidden. Now you see in obituaries, you see died by suicide, or the word suicide is actually used. And I hope it continues to be used and is not considered one of those stigma words. Some books now that deal with suicide are not being allowed in libraries, and terrible because we all have, many people have had the experience of losing a loved one to suicide. So I think what has happened is that suicide is more out in the open, even though it's still hidden. It's still a stigma. And it's my hope that the more we talk through programs such as this, through your program, Marilyn, where you reach so many people, and through anybody who's watching, to know that there are many thousands and thousands of us who've lost loved ones to suicide, and that we can talk about it openly. And so that's really how I would respond. It's changed somewhat, but not enough for me, and not fast enough to me.
Mm-hmm.
Yeah.
I would echo what Carla has said as well. The stigma is a little bit less, but it's still very much with us. And it's stigma, that is at the root of so much of this, as so many of you know who would be, watching this webinar today. It's stigma so often that impedes our citizens, our loved ones, from getting the care that they need. Because it's so difficult when you're feeling emotionally ill to be able to accept that in yourself and then go for, the kind of care that you need. And then it's hard to even kind of stick with the care because sometimes our treatment methods take time, and things like that. It even affects public health in a sense. Like, for instance, even the funding that we get for research into severe mental illness and suicide research is affected by the fact that this is still, a branch of health that has that attachment of stigma to it. However, we can be encouraged by something like the Dr. Lorna Breen Health Professional Act that was signed just a little over a year ago by President Biden, which was the byproduct out of tragedy of the death of Dr. Lorna Breen by suicide very early in the pandemic. But it is much more now, sort of in the public eye. I remember, Carla, when we were writing our book too, we had Gordon, Smith, yes, do an endorsement for us because the Smiths had lost their son to suicide.
Senator from Oregon, yeah.
Yes, and then there was funding after that, et cetera, but it's slow. We have to keep fighting.
Okay, and question number 2, we hear a lot about suicide prevention, but who are the major players that are making a real difference? Who is really
You, Marilyn.
Thank you.
I'm serious because you and your group, I mean, I wouldn't call it grassroots, but kind of, you go to the people who are really feeling it. And, they say postvention is prevention, meaning that by talking to those of us who've lost ones to suicide, we can really inform the issue. And many times we are left out of that. And by your helping and learning and reaching out, to me, those are the people that are really doing the work, not just, having events or fundraisers, but to actually reach out as much as you can to everyone that on a local level. And that's how I feel. And I feel that I've met thousands, tens of thousands of survivors over the years throughout the world. And they're most affected by groups such as Friends for Survival that are working with us to understand suicide, so we as survivors then can inform humanistic doctors such as Mike and other ones who really care, and prevention people who really care, crisis workers who really care of what it's like. We can tell about our loved ones, and then we can just help inform the issue. So I think it's groups such as yours, and I think it's survivors of suicide loss who have done the most for suicide prevention. Mike.
Okay, and I'm going to work backwards and talk about old-fashioned prevention. Dr. David Satcher was really our first Surgeon General who really put this on the map. And it's now been picked up too by Dr. Murthy, who is really looking at mental illness, especially in youth, as you know, because we're concerned about a peak of suicide deaths in our youth today, especially through and coming out of the pandemic. So that also points to another huge group that's being looked at are the epidemic of substance use disorders in our society, particularly opioids, and how they interact and intersect with intentional overdoses. Trying to sort that out is never easy, but there's a lot of research going on in that because that has to be dealt with properly. Then we look at other sociological things like the proliferation of guns in our society as well. We know that over 50% of people who take their lives here in the United States die by gunshot injury. So that's just like these other things, and what we now call the social determinants of health and illness, to the inequalities and putting various populations and people within that at risk. So there's all that group. Then the next one is the intervention. And that's where we come in a way, not just mental health professionals, but also educators, looking at the warning signs perhaps in students, but also of course in our patients. And so there's an enormous amount of work going on there to try to identify people at risk earlier, and then also make sure that they get proper care and then also that care itself. And then when they say leave an emergency room or leave inpatient care, that they're followed up. I mean, it would seem so obvious in hindsight, but yet now there are more and more effort to actually have daily contact by individuals who have left a mental health facility for over the next week, 2 weeks, 3 weeks, 4 weeks, because of research that we know that too many of those individuals take their lives shortly after having some type of medical / psychiatric intervention. And then I'll finish off by just echoing what Carla has said. I do postvention research in interviewing the family members and colleagues of doctors who have died by suicide. I have met unbelievably fascinating and phenomenal individuals, survivors of suicide loss, as you two and also all of us here, who are really moving the needle on this because they're so committed to making sure that either a family won't have to suffer like we have, or a loved one will not have to die in that way, that sort of thing.
Yeah.
Yeah.
And the third question, that is really good because it goes into the third question that we have is, as survivors, is there something we can contribute that truly makes a difference? I'm just gonna kind of go by that one because we kind of answered that
Sure.
by speaking up. Back in the late 80s, the Wyrock family spoke up, and I was part of those people that went to Washington, D.C. and got the legislation
Mhm.
and worked with Dr. Satcher back in the late 80s, early 90s, I think it was.
Yes.
And as survivors speak up and can be transparent, not every survivor can do that. But those of us who can and are willing to just put it out there, my son died by suicide, and
Yes.
is willing to talk about that, it has made a difference in the stigma. It's
Mhm.
made a difference in awareness of that how many suicide deaths there are. I mean, when my son died in 77, I did not know kids killed themselves. I knew nothing about it,
Right.
you know.
Right.
But we now have hundreds and thousands of us who are willing to speak up and
Absolutely.
to share, and in a positive way. Once we have gotten to the place of healing where we can do that, can't do that when we're all traumatized in the beginning, but as we get to a certain amount of healing, um that's kind of, we can then muster the energy to
Yeah.
do something a little different with our lives, and
And,
that
and,
has
and
made a
yeah,
difference.
another group of allies are the survivors of suicide attempts as well.
Mhm. Yes,
Individuals who are
absolutely.
also speaking out, very committed to trying to prevent other people from attempting or dying by suicide.
So the next question, number 4, was, I've heard that postvention is the best prevention, and I believe that. I wouldn't say it's the best prevention, but it is another part of prevention. What this person wanted to know is, so where is the effort and funds to acknowledge the lack of practical resources? Who's funding some really good work that can make a real
What
difference?
comes to mind is, of course, Frank Campbell from Baton Rouge, who that is his mantra. And he has done more for postvention, for suicide survivors, and he runs the Baton Rouge Crisis Intervention Center, and he has what he calls the loss team, where survivors of suicide loss can connect with others right from the minute they discover their loved one's body. He's trained survivors of suicide loss to come with the coroner, come with the police, come in the ambulance, and right away make a connection to the person when you're standing there and you don't know what's going on. So one of my personal heroes is Dr. Frank Campbell, who is really one of the leaders in the postvention world. And Mike probably knows more about this than I am, but that's the one I look to for really his guidance.
The only thing I would add is that, you know, I think a number of individuals who are working maybe a little more quietly, doing research with survivors of suicide loss, trying to get funding. I mean, that's always very competitive. You're competing with so many others, but at least their heart is in the right place. I mean, we know individuals like, for instance, Dr. Sean Joe, for instance, who's really making his research is on youth, and especially Black youth, and especially Black male youth, this sort of thing. Others like him working with specialized population, LGBTQ plus, lots of things going on there. But again, always fighting for funding, you know, to continue that important research.
Is there any organization or a foundation that is putting forth the monies that are available for funding? Is there anybody in particular? I would hope there's some foundations out there that are really going to specialize in and have some philanthropists who can really afford to fund what we need funded for.
Well,
Because it is so important.
what is it, Mike, the J Foundation,
Oh.
the JED Foundation?
Yeah, the JED Foundation.
JED Foundation is terrific. That's one of them. Most of them are family funded foundations, usually because somebody that has lost a loved one to suicide. And to look for that, you're just going to have to, if anyone is interested in getting funding, it's very difficult. But there are groups that do specialize in that.
Yeah, the largest, but these are smaller grants. So is the American Foundation for Suicide Prevention, in that one of their arms. I mean, it's research, education, public policy, advocacy, etc. Is the research arm, and some of that is through philanthropy. Some is through, of course, their walks, things like that. So, and then some they make grants then to people who apply, you know, for them. And to my knowledge, it's not just biological; it's also the psychological and social dimensions of suicide prevention as well.
Great. Well, we're going to keep pushing, aren't we?
Of course.
We're not giving up.
No.
So question number 5 is something that was kind of touched on. It's a question about stigma. The language and attitude surrounding suicide seems to add to the stigma and the sense of shame. What can we do to change this? And does anybody care?
Okay, I'll go first. I love that question.
Me too.
And it's a great question. And I guess the first thing that we've been trying to do of changing the language is to get rid of commit suicide and call it die by suicide, even though it seems like it's a very small thing. It's not, because commit sounds like an act of crime or something. You commit a sin, you commit a murder, and the person died by suicide. That's how they died. So I can be obnoxious when someone's saying to, oh, I'm so sorry that somebody committed suicide. Can I just, I sound like my mother, who was an English teacher, but still, I think if we slowly change that language, die by suicide, also call it suicide, what it is, and put it out there. Stigma, it really exists. And I say that I've traveled around the world, and I've spoken in different countries, to different cultures, to different religion. I've traveled, for a New York girl, I've traveled throughout the whole United States, and I have not found a place where stigma doesn't exist. If there's anything that's universal, if people don't think anything is universal, the stigma of suicide doesn't matter what your religion is, where your geography is. There's a silence about that. I think even we who have been out there talking about it, there's always kind of a stigma because there's a mystery around it. It's not correct. People just don't take their lives. We all want to live, and then to try to understand that. So I think the more we can talk about it and try to erase the stigma, and I think the only way you can do that is by erasing the silence, and to know that the more we talk about it, I can tell you that when I tell people what I do who don't know me or anything, I have very rarely not gotten a response like, oh, I lost my grandfather, or I lost somebody too. Most people have had it, even if it's a celebrity, even if it's Robin Williams and they were affected by it or something like that. I think everyone has that. It's just a hard thing to talk about. And by having groups such as this and webinars such as this, and I hope people are listening who, haven't been able to talk about it for 2, 5, 20 years by doing that.
And I'll just add a piece to that as well. Andrew Solomon, who wrote Noonday Demons, I remember speaking with him once after he gave a talk and a book signing, and had to do with the differential effects of the word suicidal thinking associated with depression. He said individuals would come up to him and thank him for writing his book, that they too had suffered from depression. He said then they would lean into him and whisper, and I was suicidal. So that it's like not okay to talk about that. It's a little bit like they used to whisper about cancer. That's gotten a lot better. People are using the S word, so to speak, much more. The more we all use it, of course, it makes it easier for others. That's one thing. The other thing too, in a clinical sense, as Carla has mentioned, changing around, not just commit suicide, but even in medical terms, if somebody attempts suicide and is in our emergency room, or if they should die by suicide, it isn't acceptable to say they finally succeeded. I mean, success is associated usually with something positive, that sort of thing. So believe it or not, this kind of archaic and inappropriate language is really coming. And I believe that the last one, that people do care. The final point I wanted to make, Carla and I, when we were researching our book and doing interviews, we wanted to make sure that we were able to interview and have quotes from leading members of the various faith communities, because there's so much misunderstanding about the various religions and their attitudes towards suicide. And we were able to put all of that in the book, that is really outdated thinking, that all of the major religions have moved far along on this understanding of suicide, that it isn't rooted in sin.
Yeah. Sometimes when I've done training with chaplains and other medium, I'm kind of bold and I say, suicide is not about death. Suicide is about ending your pain. It has nothing to do with death. They didn't want to die, but they couldn't figure out another way to live with the pain that they got. And they're desperate. And people, we all have bumps in the road, and sometimes we get in desperate places. I mean, that's kind of the human condition, but it's the shame that's connected to suicide is really difficult. And that leads me to another question that's a little bit different, but it also is about the stigma. How can I respond or not to a person or group who have stigma against my loved one's suicide death?
Carla, go right ahead.
Okay. All right. You have that.
How do you respond to them and their
Okay. Well,
comments?
let's start off by saying, like I'm a New Yorker, and I'll tell you how I'd like to respond. Okay, and then I'll tell you how sometimes I actually do respond. But it took me a while to realize the difference between privacy and secrecy. And one can be private and not have to tell somebody all the details if they don't want to. And if you do it because you're protecting yourself, you have your own reasons to do it. If it's doing because you feel like you're harboring a secret, then there's a lot of shame. So you're not going to talk about it because there's a secret about it. So I guess if I'm generous, I can say you can educate these people, and say, well, this is what this is. If they bother you, then just get them out of your lives. And I really have known people who have been really, really hurt by others, and it's not worth it. If you can gently explain what's going on, or you care to, or you don't care to, you just walk away. You know, somebody said to me, and he said, people are going to say a lot of things to you, turn around, walk away. You have enough to try to heal yourself, to heal your grief, to remember your loved one. You don't have to deal with somebody else's problems. If that's their problem, it's not your problem. And if they want to put it on you, then you have to just think that they have a problem. And that's my polite answer.
It's kind of what I tell people too.
Mike.
I think we're ready for the next question. I agree with, I agree with both of you.
You know, we try to be nice, but sometimes our healing has to take the priority, and
That's right.
our taking care of ourselves has to be a priority first of all. And if it's detrimental to us, then, you know, maybe down the road things will be different, and we can then re-engage with some people, but maybe not. And people have strong attitudes, and we're all have the freedom to have an attitude or
Absolutely right.
ignorance or lack of caring or whatever. We're all different, but we really need to be good to ourselves.
I have had some experience with individuals who have become suicidal. And in that process, though, they've told me that they used to be very judgmental about others, or that they lost somebody to suicide. And they just never understood it. They were just very judgmental until they experienced it themselves.
Yeah. So number 7 is on a little different note. It says substance abuse, especially alcohol, seemed to be a main factor in many suicide deaths. It eventually may lead to mental health issues, which too many times ends in suicide. Where or how can we get help for someone who is self-medicating with alcohol or drugs? And in this follow-up to that is, are the professionals offering this service having and using screening tools for suicide risk when they are helping somebody that is self-medicating? So
I'll defer to Mike on this one.
Okay, I'll start. And Carla, you may think of something that you might want to add.
Right.
A very good question, because there's just so much truth to all of this. This is what I mentioned earlier about prevention of this, what we're living in, the substance use, society at the moment. But it is true that individuals, a number of individuals who attempt suicide or die by suicide do have alcohol or other drugs in their bloodstream, or at the time of their attempt, or an autopsy if they have died. Today, in all the assessment and treatment centers, generally, and I mean, this is considered the gold standard of care, that you would be doing a suicide risk assessment on any individual who is being assessed in an emergency room or in a treatment center for their alcohol or drug usage, and then connecting that, because there are scales that we use for that, as well as the scales for suicide screening too. The thing about that, of course, is that this should never just be sort of an impersonal checklist. When you are screening someone for suicide, there are the metrics, there are those standard questions that you can ask. But if you're not coming from the right place, or if you're just doing this as checking off the boxes, you are not going to get an authentic response from your patient. And that's kind of like medicine 101 or something like that. You can't be rushed. You have to be doing your best to establish some sort of trust with this individual, so that they can open up a little bit about this, or the pain that they're experiencing inside. Or you return to it in a few hours or the next morning or something like that, to get what we would call like a more accurate suicide risk assessment. But it is very, very important.
And I was just going to add something that I've met many survivors who are very confused if their loved ones died of an overdose or they were alcoholics, and they say, is this suicide? Did they just mix the wrong pills? Did they really want to die? I know, and maybe Mike can talk about it, they've come up with this term accidental suicide, when somebody is a drug addict then or takes drugs and then dies by drugs. Is that really suicide? Is it if you mix in, I can't tell you how many people have told me that their loved ones were drinking and taking pills and they died. Were they really trying to kill themselves? And that's a very confusing situation for a survivor of suicide loss. Yeah.
And this is where most of the time, but not always, the medical examiner can help with that, because it is important to family members. And yet, we were talking about stigma a few minutes ago. There does seem to be more stigma associated with an overdose death that included intentionality. Because I've heard remaining loved ones say, we've had celebrities die, where you hear in the news that so-and-so was found dead, say, of a heroin overdose, and it wasn't suicide. It's sort of like, it's kind of like throwing out there, like, so don't even go there.
Right.
As if it's okay to die by a drug overdose, but not by suicide or something. So, this is where we have to really be, I think, so careful and just so compassionate and understanding of anyone who's experiencing this.
Part of that question was about how do we, it kind of was inferred, how do we get help for somebody who's self-medicating? You got any ideas if someone in your family or friends is into alcohol and drugs, and is there any magic words to try to get them to go get help, or is there any laws? Or I wish we had a law that says, here's where you're going to go. You're going to go get help. But is there anything that we can really do to get the people that need to get some professional help with their addiction before they end up becoming suicidal and we lose them to suicide?
I think that there are kind of two tracks in a way that I think family members, first, I think many try to start, it will vary. Some will start with something like AA for alcohol, or NA, Narcotics Anonymous, when it's not alcohol, but often they'll still go to AA, even if it's, say, a problem with marijuana, cocaine, or something like that, because again, believe it or not, there seems to be less stigma associated with AA than with NA, or something like that. But the point being is that I always tell people that then if your husband won't go, then you go to Al-Anon. And with that, then some husbands will go then to AA because she's serious about this. She really means this, that sort of thing. Others won't, but that's fine. You get the help that you feel you need. Then the other route, of course, is through the medical/therapist route. If there's any way that your loved one would talk to the primary care physician or other primary care personnel, whether it's a nurse practitioner, or maybe go directly to a therapist, and especially if it's somebody who's actually trained in alcohol and drug counseling. But for some people, that's too intimidating. No, I don't need that, when actually they probably do, but they're not ready for that. We have something called motivational interviewing now, which is trying to help individuals at the very early stages of this disease or this addiction, when they are kind of doubting that they're actually addicted, but yet the family may feel that they are. And you try to work with them again in a more collaborative way, as opposed to trying to hit them over the head with it, that look at blah, 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 because that often just doesn't work, that type of approach. So those are just some general comments about a very serious and difficult problem.
I would also add to that, if anybody is struggling with addictions, get the guns out of your house. Get the guns out. it's the major cause of suicide deaths. This method is guns, and when they're intoxicated or whatever, they can't possibly make good decisions, and having a gun that is so deadly in where they can get to it.
Right.
This is one of the major things that's really important, is to get the guns out of the house. Give them someplace else, somebody else to keep them. It's not worth the risk. So, number 8, I know it won't change the outcome, but I have questions. I want to ask my daughter-in-law, who was in the home the night this happened. I have not had the conversation with her. Is it okay after 10 months to want/need to have questions answered? Suggestions on how to gently ask for her side of the story.
Okay, I'll go first. I think it's okay to ask after the first 10 seconds. It's how you ask, if you ask non-judgmentally, because suicide is such a mystery. And we turn over and over and over again, and can go through the first minutes, seconds. We just keep going over what happened. And you don't even know your daughter-in-law might really welcome the opportunity to go over step by minute with somebody she knows loved her husband. On the other hand, if there has been some expression of judgment, like what did she do, or if blame, then there might be some resentment. I think the most important thing is to clear the air, to make sure that there's no resentment. I'm not asking you these questions because I want to blame you. I just want to understand him, not you. He's the one that took his life. You're not the one that took his life. So I think sometimes people, whether they're loved ones or friends, they ask questions that may sound prurient or that gossipy, and they're just, well, what was really going on? But if it comes, and we have radar, we suicide survivors, we know that if somebody is really just asking just for a gossip situation. But if there's somebody who really wants to know and really wants to care and really wants to try to understand, and I think that, I'm just using this case, the daughter-in-law can probably learn from her mother-in-law, because she got the husband fully grown, so she can maybe learn something about his life when he was young. So I think as long as there's no judgment involved, or if there was, to clear that up, I think it's perfectly fine to try to understand what happened. But if the daughter-in-law or the person feels up against the wall and doesn't want to do it, I guess I wouldn't push it until they feel ready to discuss it.
I like what you've said, Carla, because this question is worded, I feel, in a very careful way, that this is obviously a thoughtful writer, who has submitted this. Is it okay to need to have questions answered? She uses he or she uses the term conversation, because as you know, the questions may not even be able to be answered. They can both have a discussion, a conversation,
Right.
and fine. But just as you know, just having that discussion can be such a relief, even if questions can't be specifically answered. And suggest how to gently ask her for her side of the story. I think maybe what the writer means, just even her observations or sentiments or her thoughts. I think the setting in which they do this would be important as well. And that it's also just on a one-on-one, that it would really just be.
Yes, I agree.
Them, and that so it feels safe, it feels private. Just maybe with those kinds of safeguards in place, that there's no hidden agenda. This has just got to do with healing.
And healing together, yes.
Healing together.
Yeah, healing together. Absolutely. Number 9, as grieving parents, how can we generate conversations with our adult children about their sibling who has died from suicide when they haven't spoken about them since the death years ago? That's a common scenario in many families.
And it's not just common. It's not just common among siblings. It's common for people who've lost their parents. and they don't talk with their siblings about their parents' death, even whether they were little and don't remember but were told, or they were adults or they were teenagers. And that is such a common scenario, as you said, Marilyn. Sadly, it really is, because it gets harder every year. It gets harder not to bring it up. And I've met survivors who sort of like 10 years, 15 years down say, I want to break this silence. I want to talk about the person. And that is, I would answer that question, just go for it. Just start the conversation. Maybe not all out, but start it, and the conversation should be had.
Yeah, I can imagine that there's probably, again, this, as you said, this is so common, and there could be different reasons too. Why now? They say as grieving parents, they may be also saying as grieving aging parents.
That's right.
You may be thinking, we would love to be able to talk about this before we pass, before we die, or something like that. It would give us just a feeling of intimacy or something with our adult children, that we were able to do this. They use it as died from suicide. I guess they would have to really it sounds as if the adult children have accepted that indeed the death was by suicide. I only say that is because sometimes individuals don't, and they feel that the rest of the family has bought into this suicide business, but it really was an accident, that sort of thing. And, I only put that out there.
And I would also add to be brave, because they may turn around and blame you, and they may have had and they may say, well, my brother and my sister died because of the way you treated them, and so, be prepared for that. That may come up too. And, it's better to have the conversation than to have a screaming, yelling fight. I mean, if you're going to go there, if you're going to open that box, then you have to be prepared to tell your truths as well. And not just, why have you been so silent? And if they turn it around and say, because, he killed himself because of the way you treated him, it's really good to just air any of that stuff out.
And the one thing I would add is that they might consider imposing, if they decide, as you say, Carla, go for it. They might also consider one other alternative, which would be to put out the option of doing this with a therapist.
Yeah, absolutely. Yeah.
So that everybody would feel that this is maybe a safe place to do this with individuals who are trained and comfortable with this subject, and the strong emotions that could, as you said, Carla, could arise, the blame and the rage and, the old hurts and wounds that have just been buried for such a long time. But it could be, there's the potential for it to be very healing.
Yeah, absolutely. And sometimes adult children don't bring it up because they think that it's going to be hurtful, and the parents are going to start crying and
right, they're protecting them.
Handle it. And they just they do it sometimes as protection. That is one of the reasons that can happen. My other suggestion sometimes is to have a special meal and cook something that your loved one, if it was a sibling or your child, say your child really liked a particular lasagna or something that you made, and invite them over and say, I made this today because this was quote David's favorite food, and I just thought we could all enjoy David's favorite food. I still miss him a lot. Period.
Nice. Yeah.
And whether you can pull that off, that might be one way to kind of gently tell him that I still miss him. And
well, Marilyn,
and sobbing, because then they're going to think that just upset everybody. But when you can get to the point maybe of just trying that's one possibility you might want to consider.
Marilyn, you've done that beautifully, I think. as a healthy role model, because you're doing two things there. You're honoring your deceased, in this case, child, by cooking their favorite food, but also you're disclosing, you're speaking from your heart.
That's
It's
right.
been 27 years, but I miss him.
Yeah. And particularly, I think what I've found is, when I hear stories, it's usually the siblings, your children, is the men. And it's the men who are killing themselves. And they don't open up. They don't interact. They don't let us know what's going on. Something often adult men,
Yeah.
children, aren't going to tell you what their struggles are, because
Mhm.
they're supposed to be able to manage in our culture. They're supposed to be able to take care of things
That's right.
and make decisions, and and have it, have this big trophy house and a trophy wife and a trophy family, and there's so much pressure on men in our culture. It really is.
It's hard for them to show their vulnerability and to break
Yeah,
down and
yeah,
cry.
yeah. So I think there's all kinds of reasons why sometimes there's no talk.
Yeah.
But I know I've got a couple of adult boys, and they don't bring up a lot of stuff, as much as the girls might. Yeah. So it's kind of the nature of men. We're made different. So so the last question is, knowing we all grieve differently and our sadness varies from day to day, when will I know if I should seek professional help from a therapist?
Mike, do you want to?
Okay.
I'm gonna let Mike like wrap this up. But
Okay.
I just know from people that I know that have gone through that, when it really becomes kind of obsessive and ruminating, and they keep repeating it and repeating it. And I'll have met some survivors, and they say, Carla, I just can't really, I can't get past it. I can't get past it. And I say from day one, I mean, I always say, oh, I went to a therapist. I went for several years. I went to groups. I went to help immediately. And I think the faster you can get help. And I respect the field of therapy, and I respect a neutral person helping me guide through these very scary roads. And so I say to everyone, if they're able to, even if they don't feel that they're going crazy with this, because when you lose someone to suicide, you really feel crazy. You feel crazy for the first couple of years, like what happened? So the more help you can get, the better. And I would advise it universally if it's possible. So
Yeah. Yeah, I would respond in two ways. I would agree with you, Carla, on those sentiments. I think if I remember correctly, in the book too, we put a section for sort of, in a sense, early grievers who actually were feeling quite physically ill. Like, in other words, there was concern about their appetite, their weight, their sleep, their energy, where they themselves actually felt ill. And I think for those loved ones who were around them, it was kind of frightening. I mean, they're not minimizing the magnitude of their loss, but they want them to be able, though, to kind of just get through it on a day-by-day basis. And especially if the person themselves, if they volunteer, they say, it's now been 7, I thought I was making a little bit of progress, but the last 2 months, I feel I've really gone backwards. I've lost 17 pounds, or, that's serious, all that sort of stuff. So that's, I think, easier to get kind of medical/psychiatric care. With other ones, though, it would probably be a similar sort of thing, but much milder, that they say, look, it's now been whatever length of time. It could be 15 months, it could be 2 years or something, where they say, I've talked with other survivors, and I know that I will always grieve, but I just feel, just as you said, Carla, that I'm kind of stuck in some respects. But I don't use a short one. Do I use a longer one? I feel no differently than I did, say, 6 months ago. or in fact, I might even feel I've gone a bit backwards over the last 6 months. And then they might get specific about the ruminations or intrusive thoughts that are coming into their mind and things like that. And I think to approach therapy even more from the standpoint of, look, you got nothing to lose. Why don't you could just try one visit?
Right.
Yeah, because obviously it has to be a good fit too, with the individual, and hopefully the person that they would go to is somebody who's experienced, comfortable with this subject, that sort of thing. And as you said, Carla, can give that sort of clinical sort of, objectivity or special approach that they can help with the, with the next steps, with the guidance and all of that.
But, talk about stigma. There still is a stigma to go to seek help, to go to a shrink, to go to a therapist. There still is that kind of stigma that, you mean you can't do this yourself, you can't figure this out, and so that has to be also addressed, that there shouldn't be a stigma, just the opposite. When you
Well,
go,
yeah, Carla, that's why you and I have talked about this, and it's actually now in the science as well, that normal grieving in suicide bereavement is very different than if you'd call normal grieving when the loss has not been by suicide. So there's got to be sort of a wide, range of, parameters there, because you don't want the person to feel that somehow, why is this taking so long? And this is where, Marilyn, this is obviously where your groups come in, because you can be so comforting and supportive of each other because you've all been there. Sort of, all of that. And that's what, as you know, this is what people need to hear. So reassuring.
Yeah, it is a long journey, a very long journey, and it is different.
Mhm.
But that's true about almost any kind of death. When it's a homicide, it's different, and you know, different deaths have different complications. And this one, just the trauma, the violence of it, and
Mhm.
a loved one that died alone, most of the time, died alone, desperate, unhappy. That's what hurts. That's what hurts so bad. That is a big, huge part of it, the hurt. If we could have just held their hand while they were dying, just a regular kind of death from illness, it's very, very different. So I want to thank you so much, the two of you. It's been a wonderful time to have you as our guests on this webinar called Ask the Authors. If anybody's watching this, contact Friends for Survival. And if you've got any other questions or any way we can help you, we're available. You might let people know that maybe to watch this webinar, refer people to look at this webinar and maybe glean some information and understanding and some suggestions and ideas on how you can better cope. That's what this is all about. That's what we're all about. And we just are grateful that we can have Zoom meetings. You guys are both in the New
Right.
York
Thank you.
area, and here we are in California,
We
and
like
we
that.
can pull this up without getting on an airplane.
Yeah, that's great.
Then
Well,
absolutely.
one day I'd like to get in there on an airplane and visit you guys out there. So
Oh, come out and see
keep
us.
that invitation going.
Okay. So thank you so much to Carla Fine and Dr. Michael Myers. And thank you so much it's in the past of writing this wonderful book called Touched by Suicide. I've got to look at my notes to make sure I say this right.
You said it right. You
First,
said it
don't.
Right.
Touched by Suicide, Hope and Healing After Loss. So, but it is specifically really about suicide mostly. It just isn't a
Yes.
regular
Yes, it is.
death. We're talking about suicide deaths.
That's
Yes.
right.
So, and I've been trying to add that when people use the word suicide, is say suicide death. So we can get more comfortable and more specific on what we're talking
Mhm.
about.
Absolutely.
So anyway, thank you so much.
Thank you
Thank
for
you.
having us.
Yes, I'm
Thanks.
so glad that you were willing to do this for us today. Thanks.